So we'll just change it around, and I'll ask Dr. Ramesh Dorairajan to talk about the biometry do's and don'ts and the latest updates in biometry. Is that okay? You can ask them to then. Adit, can you ask them to put on the biometry talk first, please?
Mohan, sorry, Arul, I can open up here. It's not a problem.
Okay, fine.
I think they had to help me because this is jumping like mad. He's doing it there. Oh, here. Thanks, Arul. So, can I go ahead, or because your mouse is still moving? Thank you so much. So we have to start the talk by the greats in biometry, Dr. Warren Hill, Dr. Haggis, the only mathematician and non-ophthalmologist in this group, Graham Barrett, we have all used his formulae, Thomas Holson below him, and Dr. Jack Holliday. So, sorry, that is Douglas Koch, and this is Olson. We know that the 2008 JCRS article by Savarkar and Norby told us that the common causes for biometry errors are as follows, and ELP estimation, that is formula error, is the most important thing. Today we know that the earlier generation axial length error has largely been conquered because of the widespread use of optical biometry. Haggis 4 years ago, before he passed away, remarked that we cannot expect to have improvements in measurement of the axial length because now pulsations in the eye caused by heartbeat can now be measured by accurate optical biometry. In spite of all this, we have not reached 100% of our patients getting 20/20. 2 years ago, Dr. Warren Hill in our state conference gave a lecture where he said, if you are getting about 78 to 80%, you will get a pass mark, that is within 0.5 diopter of error, and 92% plus is achievable by those doctors who concentrate on every step of biometry. If we continue to use manual keratometry in 0.5 steps, and we are using one of the early generation formula like SRK2 or T, we are probably at 70% plus. But if you switch over to SSOCT based biometry and one of the more recent formulae, which is all available free and online, you are going to get 90% plus. The advantages, so that is it, we have to switch over. If you want to have better results, we have to switch over for better acquisition of data, the machines have to be better, and the formulae have to be better. Axial length is no longer the issue, but cornea is the issue, and this has been extensively covered in the last few years. We have to optimize the cornea before taking the measurements of the cornea. The advantage of the newer generation biometers is that they are more accurate as far as cornea is concerned, and we get a whole set of new parameters that we can measure. For example, we can get a true corneal power by OCT-based machines, which are going to measure the front and back of cornea, and they reduce the common mistakes our optometrists make. Most of us are not doing the biometry ourselves. The mistake that the operator does is reduced because they have checkpoints which check for these errors. For example, here's a patient who had anti-VEGF injections in Trichy who came to Chennai for a surgery. On the slit lamp, he just had a white cataract, but the optometrist picked up the small tear of the posterior capsule there because this shows up easily in the IOL Master 700. So in this particular patient, we know before we take up the surgery in a white cataract that there's a tear of the posterior capsule. Then if your optometrist finds this kind of Myers, she will know that you have to ask the patient to blink. This is not good enough to do a calculation. You have to either make them blink, make it better, or you have to optimize the tear film. Very dense cataract, poor vision, we will easily miss this macular hole unless we do an OCT for all our dense cataracts. But this will be picked up by your new generation SS-based optical biometers. Can I have the next slide? The older formula were all one-line formula. They just had one-line calculation. This is a Hoffer Q, this is the Haggis, one single line, which they apply to all eyes. small eyes, large eyes, buphthalmos, nanophthalmos, post-LASIK. So the older formulas are all one-line formula applied to all eyes, and that will not work well for the unusual eyes. The modern formula have different calculations in different situations. Post-LASIK has its own calculation, keratoconus has its own calculation. There are all multiple different formula depending on pre-op whether you choose, which one you choose. The SRKT that many of us were using till 15 years ago is actually first described in 1990 based on a data set, small data set of 1,677 patients. Imagine 35 years ago, a very small group of Caucasian eyes were used to optimize SRK2 and T. But many of us are still depending on that. So if we cannot get perfect results if we do that, the modern formula try to optimize every bit. For here you have lens thickness, and this is called the power prediction curve. So in different formulas, they find that if you have a 6 millimeter lens, you're likely to get a more hyperopic result. So they'll write one line of code, and they'll say lens thickness more than 5. Please add a 0.25 and flatten the curve. So what they do is they take each segment, corneal power, ACD, white to white, lens thickness, these modern formula, try to make the power prediction curve flat for each one of these lines. But it is not perfect, and it's not perfect because these power prediction curves are based on a scatter plot. There are individual variations in any set of data. So even though you have a single straight line here, it doesn't mean that everybody is on plano. Some will be a 0.1, 0.2 above, and some will be a 0.1 and 0.2 diopter below the curve. The power prediction curve is just a mean of a large set of data. Because of issues also with IOLs being in 0.5 steps, and because of power measurement errors which is possible, that is an intraocular lens which the manufacturer thinks is a plus 20 lens, his machine shows plus 20. He is permitted, and the machines have an inbuilt measuring error of 0.18, standard deviation 0.1. So a 0.2 error is there in the manufacturer at his machine end itself. He also does not know. These small errors, 0.1, 0.2, can cancel each other, or they can summate, and once in a while you will have a patient with unusual refractive result. So Douglas Koch in the CRST 2023 review said that 90% accuracy is probably a ceiling given the current machines and the technology which we use. Patients must be informed they have a 1 in 10 chance of having a residual refractive error. We have to tell them this. The modern formula are mysterious black box solutions. We have no idea what is happening. We just feed in the data online and something goes on behind that. They're using cloud-based computing, not a small computer in some particular lab. This is modified from Warren Hill's famous list of different kind of formula and what they and the set of eyes which they are good with. But here's the interesting part. I modified it. Evo, Kane, Pearl DGS, Hoffer QST, Full Monty, currently not available online, Nallaswamy, Kimura, Lada Super Formula, AA version. All these are new formulae which are living formula. They are getting updated every 3 to 6 months and they are improving. So among AI-based formulae, we have the pure AI, Hill RBF, Kimura, and the Nallaswamy, and the partial AI, Kane, Pearl DGS, Hoffer Q. So which one of these various modern formulas is the best? This is a 2024 review by Sopera et al. Seeing all the publications on AI-based formula, and they came to the conclusion that every surgeon who has done this formula thinks he is the best. But if you see those with large number of studies, Kane is the best. So if you want to use any one formula, please use a Kane formula, and all these formulas are going to improve with time. They are not static formulas. They are all living formulas. Last week, I had a patient who had a 0.75 error, and he was implanted after Kane and Barrett's. They both gave the same sphere and cylinder. And post-surgery, pre-surgery, it was almost the same. The K was not much different. When I looked at his values, he had a long eye, 24 millimeter long eye. He had an unusually flat cornea, not post-LASIK. The true K and the actual K were all 39-40, flat cornea. Lens thickness, normal lens thickness is 4 millimeters, standard deviation 0.2. This is at 3.6. It's an unusually thin lens in a flat cornea and a long eye, and the formulas have not given me a proper result. Is gender a factor? After seeing more than 2 lakh eyes, Savini et al. A few years ago came to the conclusion that males have longer eyes, flatter cornea. Gender is a factor. And the current generation formula like Kane and Hill RBF will ask you whether you are calculating for a lady or a male patient, and they will give you 2 different results based on that. Can we Indians use formula optimized for Caucasian database or Chinese database? No. Indian corneas are steeper, our lenses are thinner than Caucasians. So truly, if we are happy with one particular formula and one particular customized constant, if you're operating on a Chinese patient or a patient from who's Caucasian, we should modify it slightly. So in summary, to get good results, optimize the corneal surface, use a SS-OCT based biometer, use the Kane formula. Accept that 1 in 10 or 1 in 20 patient will have an error equal to or more than 0.5 diopter. Please inform the patient once in a while and you can expect further improvements. All this comes at a cost. The IOL Master 700 before COVID cost us about 31 lakhs. Today he is listing it at 40 lakhs in just a few years. A few months ago, it started giving the wrong date and he said he wants to change the battery. So when the technician came to change the battery, which powers the motherboard of the IOL Master 700, he spent some time and he said it is stuck to the motherboard has to be changed. So he changed the motherboard instead of with the battery and he gave a bill for 6.28 lakhs. So individuals who want to use these machines have to be willing to accept this kind of cost, or better to have group practices or use a common center and use the machines there. So we are at the cusp of understanding how better quality measurements and large population-specific database will improve our power calculations. Things are at a flux. At present, use the Kane formula, where Kane is not applicable like in you want to do a lens rotation. Please use the Barrett's. Thank you.
The patient which you showed, what formula did you use, sir? You had an error of 0.75.
Both.
So both Kane and Barrett agreed for that particular patient. There is no difference in the IOL power which they both suggested. So well, the point is, even if you are using a very good formula, once in a while, in a year, 2 or 3 patients, or once in a while, you will have this.
I'll throw another question at you. This particular patient who ended up with 0.75 off the mark, would you attribute it to the flat cornea or to the ELP of the lens is going to be different because the lens was thinner?
That's what I was thinking, Arul, and I really don't know. I think no, they have enough data sets for the steep and long eyes. They don't have enough data points for the small, thin lenses.
Exactly.
So probably the lens portion is anterior.
Because all these formula have been tweaked for post-LASIK. And they work brilliantly in post-LASIK because you have a flat cornea. So take out the flat cornea here. So what we can understand now, when you have a thinner lens,
Weaker
then the
lens.
chances of
Getting
going off
myopic result is more. Make it one step weaker.
weaker, simple.
Yes,
So
sir. Came to the
now,
same conclusion.
why don't you put up a paper on this? A simple mathematical calculation
Okay.
saying with a Barrett Universal 2, for every 0.25 thinner lens from 4 mm down,
Think of
this
going
is
one
step
step
down and
You
then
can
we
think
publish
that,
it. I hope you got the thread of what we are talking about. So actually it's very easy, very simple, but this is going to come, it has to be automatic in your mind that whenever you see a patient, something goes wrong, you go back like an animal that's going after its food to figure out what went wrong. So once you figure that out, then you're ready to face the next patient. But this has to become automatic. It can't just be left, oh, I just got this wrong, and this is normal, this is acceptable. Something goes wrong, 0.5, you have to dig into it, ferret into it, find out what, and then you will be able to understand these things better and get better